Dr. Same for the hard work. I don't know how many hours he already spent to gather all the people that very dedicated in skull-base surgery to get into this very prestigious webinar conference. In my talk, I think it will continue from the previous talk. It's about the Endonasal approach for Clival chordomas. So in this talk, we'll just skip a little bit about the Clival chordoma overview and maybe discuss a little bit about the transcranial versus the extended endonasal endoscopy approach and the extended endonasal endoscopy approach. What is the differences? Why we are starting to shifting to the using the midline extended endonasal approach? How is the anatomy and possible complication? How to avoid, and then the surgical steps a little bit, and maybe some review about the adjuvant treatment and prognosis, because as we know, chordoma up until now is still one pathology that's very hard to treat. So we know that Clival chordoma is a primary bone tumor, and then we almost always see the locally destructive bone in the surroundings, and the incidence rate is actually 0.08 in 100,000 population. I know that it seems quite rare, but in the end, I think if you are working in a center where you are focusing in skull base, then you will get a lot of reference, despite the number or the rare case that actually chordoma in the population. And as we know, the clival has a complex anatomy and it raises up the surgical challenge and its proximity to vital neurovascular structure. We can almost always see the involvement of cranial nerves, especially the abducens nerves. And when we see the tumors in the base of the skull, don't forget to think about other differential diagnosis. It's either chordoma, hemangioma, dermoid, meningioma, even schwannoma, or even aggressive pituitary adenoma. So I might just skip a little bit about this. This is the overview about what we are going to see when we open the clinic. As we know, we divided the clivus to the upper clivus, mid clivus, and also lower clivus. It depends on the imaging itself. We need to study very thoroughly where the chordomas lies and where it's actually going through, like going up, lateral, or also inferior, so that then we know which area that needs to be exposed, and we will discuss after this about which bone that will need to be taken off step by steps.
Selfie, we don't hear you. We don't hear your voice.
Can you hear me, Dr. Sami?
It's okay now.
Okay, sorry. I think my
Problem
Bluetooth
was
is
about
run out.
voice.
Yeah, I think my Bluetooth just ran out of battery. I'm very sorry. So here's what we see in the radiological imaging. We usually assess the spectroscopy. We saw that there's some difference. Sometimes we can see the um, creatine going down in all of the cases, but the choline would be going up. And sometimes we can see the lactate is going up, but it's not for all cases. And choosing the surgical approaches, it's either the transcranial or the midline endoscopic approach. So here's a diagram showing if it's the clival chordomas, then we will check the imaging and also the neuro-ophthalmology, and then if it's possible to perform the CT angio or also MRI, and then we check about the staging, and we usually bring it to the multidisciplinary oncology discussion. If it's discussed to perform surgery, of course, it will be the first choice. Um, the first thing that we need to put in mind is that our target is total removal. So it's resection or reduction if it cannot be totally be removed, and or palliative care. And it depends if it's crossing the plane of a cranial nerve. If it's in the ventral, then we will choose endoscopic. Um, if it goes both way, ventral and dorsal, we need to think that we might need to do it combined or stage operation. We don't do in one settings. And it's in dorsal, of course, transcranial approach will be more preferable. And if it's above the C2, we will choose endoscopic, and below transcranial will be. Okay. And there's a paper comparing a systematic review comparing the open versus endoscopic surgery in Clival chordomas in a 10-year single center experience. It showed that although there's clear evidence in the literature that endoscopic approach provide better rates of gross total removal with fewer overall complication compared to open surgery, but sometimes it's not always possible or viable. So both approaches still need to be considered. And there's another paper comparing the midline approach, transcranial, and also endoscopic approach. The It showed that the endoscopic endonasal approach for skull-based chordomas resection has improved the gross total removal rate. But still, transcranial is an alternative approach. So, which approach should be chosen? I think um, everyone already understand and also see this chart. But I really like how in this chart it described in the very beginning when an approach is being popularized. So many people are trying to use it, like to perform to do it, and then all of a sudden we have a lot of learning curve with complication, and then we will have a discussion, and then in the end we will choose whether it's actually the correct or the appropriate approach, or we should go to other approach. And as we know that in endoscopic endonasal, it was described there are 5 levels. The transclival approach is going to the level 3 if it's going just only intradural, and also level 4 if it's going to intradural. This is just some references from the international consensus of the skull base. It showed that there are so many centers showing that endoscopic endonasal approach is an approach that can be considered for clival lesion. And before we start doing it, then we need to know what kind of complication that might happen. And I think in the international consensus, it's also very nice how they describe in the paper the possible complications, so that when we want to start doing the approach, then we will need to know how to overcome and also how to avoid this complication. As an anatomy, for the transclival endoscopic and nasal approach, if we split it to superior, middle, and inferior, in the superior part, the bone removal should be the sellar floor, the dorsum sella, and also the posterior clinoid. It will be in our way, unless the chordoma itself already disrupt the bone. And in middle clival, in mid clival, then the clival recess of the sphenoid bone need to be removed. Of course, all the truncated triangle bone, and then the sphenoid floor, and also the paraclival carotid canal. If it's possible, then it's better to take out so that you will lowering the risk of carotid injury. And for the inferior clivus, then we will need to remove the basilar part of occipital bone, foramen magnum, the jugular tubercle or medial condyle. And the and the nerves that we might encounter in the superior clival is the third nerve, in the middle is the sixth, sometimes 4, 5, 6, 7, and also 8, and the inferior, of course, the lower cranial nerve. And the lateral extension approach. So in the superior part, we will go up until the cavernous sinus, the paracellar, and also the suprasellar. And then in the middle, mid clivus, then our border will be the medial of the petrous apex and also the Meckel's cave. And the inferior clivus, the border will be transjugular tubule, infrapetrous, and parapharyngeal. So here's the anatomy picture that's showing in the supraclavian region. Sometimes if it's involved, then sometimes we need to do the pituitary transposition. It's either intradural or interdural. And here's the after drilling the clival bone, then we will find the clival dura that's usually sometimes can be involved, or all the lesion can also be uh, extradural, all of the lesion. And we need to always check and recheck where uh, the border of our drilling, because as we know in chordomas, because the bone is already disrupted. So sometimes we don't have any clear margin or bony landmark that can be used to avoid arterial injury, or even so to check whether we are already in the sixth nerve or not. So it's always important to use intraoperative monitoring and also a Doppler to make sure where we are in the resections. Okay, so here is for the lower clivus, where the border will be the foramen rastrum and also below the median nerve and the clival dura. And if you want, we can also open up until the here, and then the C1 anterior arch is there if needed. Usually in chordomas, I think the bone is already disrupted, and then the pathology itself is already help us in making way to resect the lesion. So when we are thinking about doing the extended endonasal approach for the clival lesion, we need to think, how is the lateral extension? Is it crossing any arteries? How about the nerves? And how about the consistency prediction based on MRI? And whether if we are choosing this approach alone, will we get a complete resection or not? So as the surgical steps, first of all, we need to do the bilateral wide sphenodectomies, and then it depends, but the middle turbinectomy is advised. Al- I do it almost all the time. I know that there are several papers saying that we need to conserve as much as possible, but middle turbinate is actually in my opinion, it's actually better to do the turbinectomy, especially when you are worried that if you do lateralization too much, then you will block the middle ostium, the drainage from the frontal sinus. So it's also actually um, avoiding the frontal sinusitis possible complication. And then after that, we will do the vascularized nasoseptal flap. As we know that this will be, most of the time it will need a very huge and large the nasoseptal flap. Um, we can actually, can you hear me? Sorry.
Yes, yes, it's okay.
Okay, thank
Please
you.
just carry.
Okay. Okay. Um, yeah, here I'm just gonna go fast here. So this is also an important key. So there's papers measuring the surgical freedom of the anatomical target. So if we remove the bone as much as possible in the anterior part, then we will have more range of movement. So the removal of the sphenotostrum must be done very thoroughly. And then drill away the cellular bone, the disc dura. This just want to show that the depth of the bone is not actually always in a very nice direction, but it's like a triangle. Okay, and I'm just gonna skip that. And then during the clavicle bone, and then exposing the clavicle dura, open if necessary. If lower loop clivus involved, then raise the nasopharynx muscle might be needed, and then the closure is maybe sometimes maybe afraid about the CSF leak is maybe one of the reason why some people reluctant to extend it to the clival recess, the to do it endoscopic transclival. But actually, if we follow the inlay, onlay, and overlay technique, then it will be very, really helpful. So this is the panoramic view in the end of the surgery. So it's also need to be considered that larger defect size versus the overpacking, because we know that it's directly contacted with the brainstem, so we need to be very careful if not to overpacked. And um, there's some papers saying that in the present of learning curve, it's actually will be dropping dramatically after 4-year periods, but maybe it needs some number. It's not only for some years. So here's how we do it in our institution, um, forehand technique with my ENT. And here's a female, 45 years old, presenting with um, visual disturbance and also sixth nerve palsy, and middle turbinectomy, and then trying to raise the flap and then drilling the rostrum, open up the anterior wall, and then we saw that the tumor itself already made its way. We just need to check and recheck whether we are encountering any nerves or also arteries. So here we can see that the tumor is very soft, and it's very nice to do this endoscopically, because this is very cooperative tumors. The biggest problem would be deciding where's the six nerves are, and also the arteries involvement. Yeah. So we try to remove as much as possible, of course, with intraoperative monitoring, with Doppler guidance, and also the navigation, and try to do the removal if possible with double suction, just to make sure that we do not do any encounter any complication that need to be avoided. And here's the closure, the inlay, and then we are using the free flap from the thigh, and then the vascularis flap. Here's the post-op scan and also the post-op MRI. Okay. Um, Here in the pathology, just want to show a little bit that it really is destructing the bone. So here we can see that the bone is already destruction with the chordomas itself. So it really goes in between the bones. That's why it already made its way, helping us to reach the tumor. And I think Dr. Sekar trying to propose there's a grading for chordomas that will help us um, seeing whether we need to do adjuvant therapy afterward, and also how about the summary of the residual tumor location after the resection. Uh, and chordoma should be treated as locally malignant masses with the potential of metastasis. Multimodal therapy with adjuvant radiotherapy at superior for local control and also the overall survivor. But however, post-surgical radiotherapy and gross total removal, the recurrency, it's still 30% of patient at 5 years. So we still need, we still have a lot of homework regarding chordomas. And the doses, there are several different consensus. And nowadays people start to use proton therapy, but unfortunately in my country it's not available, so it will be very hard for us because we need to go and redo several times because of we don't have any other resources. And after that, for the patient itself, we need to think either this patient already need to go to the palliative care where we cannot do anything more about the patient or not. In conclusion, Clival is complex anatomy, raising surgical challenge, and its very proximity to vital neurovascular structure. We can choose the surgical approaches, transcranial or extended endonasal endoscopic. It's very important to have a thorough preoperative planning, surgical steps, trying to rewind and make sure that the surgical steps is what we are following. So do not skip any steps. And we need to know the complication first, and then we need to prepare if it happens. Then do we have the correct team? Do we have the angio suite ready when we are doing the tumor that involve the uh, carotid or the arteries? And do we need lumbar drain to prevent the CSF leak? We need to make sure that we already prepare before we start the surgery and choosing the endoscopic endonasal approach. And we also need to think that it's a multimodality treatment for carpal chordoma, so we don't need to, I mean, we need to push, but if it's the border, then we need to consider wisely whether if we are going in, it's for us or for the patients. In conclusion, also with the international consensus of the skull-base surgery, the benefit for endoscopic endonasal approach to the Clival region give an opportunity to decrease surgical morbidity for midline lesion. The direct comparison to traditional open approach, lacking of the literature, and the surgeon and patient should be familiar with the potential of brainstem injury, the vascular injury, and the potential for transient or permanent injury to the sixth nerve, abducens nerve. And we need also to consider, we want to do the gross total removal, but we also need to think the percentage of possibility of the postoperative CSF leak rate. And as a recommendation, it can be utilized in midline chordomas, in skull-base centers with sufficient expertise and experience. So we need to have the team ready. And the endoscopic endonasal approach is feasible, including conjunction with an open approach. So we can do stage surgeries for certain chordomas, especially with the lateral extension, and also sometimes in the lower clivus if it's involved in the dorsal part of the neurovasculature. And Clival chordoma may be treated with endoscopic endonasal approach as part of multidisciplinary approach to the treatment of this lesion. I think that's all that I can share for today, and would like to invite you all for the annual meeting Asian Society in Neuro-Oncology 2 weeks from now in Bali. Thank you very much, Dr. Same.